everybody. Do you hear me? Is it okay? Okay. So I'll start with a few sentences. The level of the presentation that you heard before is different from what I'm talking about. I'm a physician, an internal medicine and a primary care physician. And actually, I was brought back from Boston to Israel, to Sheba, to build and direct an innovation center that is based on all the data that was accumulated at Sheba. I can't hear you. You can't hear me. Okay. So I believe that now it's better, right? So the center, my center, is really based on all the data that was accumulated at Sheba. From 1994, Sheba has electronic medical record, which is quite astonishing for other countries. In all Israel was actually computerized, healthcare was computerized in the 90s. And based on the data, actually, we're developing our products and technologies and bringing new technologies. So, not so sure. So Sheba is the biggest hospital in the Middle East. We have 1,900 beds. It was announced as the 10th best hospital in the world by Newsweek about a few months ago, 6 months ago. And a lot of research and innovative products were created at Sheba, either in the molecular world, pharma, or in medical devices. This is the first time the new CEO that started about 3 years ago, Professor Kreis, that actually Sheba has decided to put some kind of effort around digital health data and what we are doing also in AI. We, the deputy of the hospital, Dr. Zimmerman, decided to build a new strategy for innovation, and we put together the strategy in the form of ARC. We call it ARC, A for accelerate processes. So the idea is really to create processes that are quite fast, between 10 to 12 months. Redesigning healthcare delivery. So everything that we are doing is really about how we are going to change the way we deliver healthcare. If so far, actually, we are waiting for physicians, for patients to come to us with some kind of complaints or pains or any other symptoms, then now we are thinking about how we can prevent, and as you heard before me, like taking into molecular markers and more than that, how we can actually change the paradigm. So instead of waiting, like we are going to identify early, create a way to take care more personally according to the specific data that we get on a specific patient, and everything comparison to a big previous cohort that we have. And the C is for collaboration. We collaborate with healthcare organizations, academia, nationally and internationally, and the idea is really to, first of all, to think together about problems, because we all have the same problems more or less, and also to share data and share technologies. So what we did is we decided to put under one roof all the stakeholders that play a role in that redesigning healthcare, the way we see it. On the first level is really physicians and researchers, at this point from Sheba, but it really doesn't matter because we are going to open up our projects and plans also to other researchers and physicians. And I'll give you some more insights into that. So what we do is we decided to, we got philanthropic money that we give to projects up to $50,000 at this point, to projects that can that are based on data and AI, and can use either our data or accumulate new data that we still don't have, and create these models that will predict either a reaction to a medication or a deterioration of a disease, and we'll see the examples. From outside, the idea is really about startup companies, companies that come to us with their own technology. In Israel, there are about 500 companies in digital health, and they come to us with the technology, and we take those technologies and try and screen them and see if we really want to adopt them, number one, if clinically it makes any sense. So we always bring the clinical director of that specific theme. So for example, if the company is dealing with psychiatry, we'll bring the head of psychiatry, and once we decide that technology is good for us, we start a pilot. We design it appropriately. We go through the ethical committee appropriately, and we created a pilot that actually can be published later on, because actually the physicians, they care about the publications. We care about bringing new technologies, and the startups about actually validating their technology. The third partner is our strategic partners. We have a few of them, many pharma companies. I will elaborate a little bit more about the work with Microsoft. In academia, we bring students from all over the universities. We bring professors. We really want to try to bring the data science into, to put a light on the data science within a hospital that actually concentrate more on medicine, of course, and taking care of patients. The yellow arrows, the idea of them is that every project that we do, it doesn't matter on what the goal of the project, but every project has really components of many of those stakeholders. So we try really to mix the vectors and the efforts that every institute brings within. So for example, if we do a project in data, the physicians will always lead it. The startup company can bring their own technology of analyzing, for example, slides in pathology, and the strategic partner will try to bring a partner that actually wants to have this kind of product, like the company who creates the machines that screen the slides into the computers. So we always try to see how we can collaborate and put together all the stakeholders in one project. So we'll go a little bit to more details now. So from within, like I said, we have money to give to physicians and researchers to come to us with pain points and needs, and we try to bridge the differences in the languages and in the cultures between the data science world and the clinical world, and to understand the needs and pain points that physicians come with, and translate it into an algorithm or a model that the data scientists can develop. So I put here 4 examples. We have about, we have 20 internal projects that are running, and about 10 of them at this point are dealing with machine learning in the machine world. So predict development of complications in the NICU. So the NICU it's the intensive care unit for neonates, for premature babies that were born. Again, Sheba has actually the biggest NICU and the oldest one in Israel, and we have all the data that was accumulated. So we deal there with data that comes from monitors of those babies. We have, of course, the blood tests that were taken during their stay since they came to the NICU, and we have radiology data on them, normally ultrasounds, no really X-rays on these patients, and also heart monitors and heart echoes. And now we are trying to develop a model that can predict 4 different pathologies that those babies might develop within the NICU that can cause a long-term disability or has a lot of clinical implication of what will happen with those babies, if they will survive or not, and what kind of health they will have. Dealing with the data, we realize actually that the data that comes from either imagings or monitors are really the ones that we want, and it's easy for us to deal with. The electronic medical record, I don't know how many of you actually dealt with that, but it's extremely difficult. There are 2 things that you can take out from, maybe 3 things that you can take out easily from an EMR, which is the diagnosis, and again, if the physicians actually really documented it well enough, the medications, again, if it was well documented, and the labs, of course. Otherwise, everything else is a free text. Most of the data is in the free text. About, I would say, 70% of the data that actually we need is in free text. So the tools that we need to develop for the NLP tools are very substantial. We deal, and that's not something that is easy to do, because even the free text is written in different ways. It's written English in Hebrew words, and even other languages. We see even different languages that we shouldn't actually see in the free text. So what I'm trying to say is despite the fact that we're really trying to develop those models, we come to a conclusion, like often more than we thought, that the projects we have hard time to continue the way we thought that we want to continue, and we concentrate on the data that is more coded and that is more imaging, or again for monitors. But this one is one example. The second one is we have a big cohort of patients that were hospitalized with congestive heart failure at Sheba, and we are trying to take, and congestive heart failure is a lethal disease that actually somebody who is of the elderly people mostly, and we saw studies in medicine show that many times it's really, once they start being hospitalized for congestive heart failure, those patients have a few years to live, even less than that. So it's extremely important in all healthcare systems to try to identify how you really want to take care of those patients within the hospital, outside of the hospital, what kind of medications, and how come we don't cause even more complications than what they have already. So what we do with this cohort of data, we try to identify, at this point, kidney injury from medications that we give them. So some of the main treatment for those patients is really to diurese them, to give them diuretics, and in order to get rid of fluids. So, and the difference between taking care of them in a good way or causing a kidney injury is very, very small. So we're trying to create now a model that can predict who will develop a kidney injury from the treatment, who will need to be, once they discharged, who will come back to the hospital as a readmission. That's a very, this has a lot of value in the American health system, because hospitals are getting penalized for readmissions within 30 days. So actually we're working a lot with our own internal projects, but also with companies in order to see what will actually be interesting for other healthcare organizations and not only here. The third one is we have a huge cohort of patients, healthy people, totally healthy people that come to do their screening tests at Sheba. Mostly are people in a high level of socioeconomic level, and they come and follow up over the years. Like we have data of 20 years already of those healthy 40 and above older people, between 40 and 70. So there we realized that if we look backwards on the data, we will be able to predict who developed a chronic disease along the time, because we have such a long history of those patients. We started now with who will develop eye disease. We started with glaucoma, just because it's so difficult to diagnose it. It can cause blindness and has a lot of implications. But any kind, if some of you will participate at the hackathon, so I brought 2 data sets. One of them is this one. And once somebody really wants to go deep into this data, you can really try and predict many other chronic diseases that people develop. The good thing about it is you have the outcome. I mean, you don't have the outcome of everybody, of course, but for those who stay there for 10 to 20 years, you really know what happened with them over the time. Since all the data is normally here. Those patients come again and again to Sheba screening center. And the fourth one that I want to tell you about is really looking at, there are about 4 to 5 very common eye imaging tests that ophthalmologists do. Since we have them really in very high quantity in Sheba, we're trying to see, and there's some studies that show that there's a correlation between so you can actually maybe detect dementia in some eye imagings. So we're trying to do that. We take all the fundus imagings that we have and the OCTs, which is a CT of the retina at the back of the eye, and try to see if we can really detect early dementia in patients that have a relative with dementia. So at Sheba, we have also a big center for brain studies, and we have those patients in big numbers in comparison to other places. Now again, what does it mean, big numbers in healthcare? I don't know how many of you worked with healthcare, but if you're used to numbers like in the fintech world or other worlds, I mean, we don't have, normally if we start with a cohort, like you saw also before me, he started with a cohort of 1 million patients and then ended up with 90,000 patients that actually fit his criteria. And that's what really happened. I mean, we start with big cohorts and then we realize that either we lack the data or they don't really fit of the inclusion criteria that we want. So at the end of the day, we have to deal with a much shrinkage cohort, but it's still quite a lot. Those are the examples of the companies, startup companies that work with us. Do you know them? Does anybody know the companies? So most of them are, like I said, AI-based, but not only. I mean, we have companies that do digital health, so remote care. So for example, this company, Datos, started really as a small one, as a project, as one of the pilots with us of taking care of patients remotely who just had heart attack or open heart surgery. So we created a program for cardiac rehab, and this project was good. Everybody was happy. Patients were treated nicely outside of the hospital. And actually, since then, this company became the main provider for telemedicine for Sheba. So they won the bidding. This is an Israeli thing to do a bidding thing. But now they became the main company that provides telemedicine for a big hospital. I mean, a small company for a big hospital. It means that if startup company starts with a pilot and it's going well, we would definitely recommend them to stay. And we do a lot. I mean, there was a lot of input from the innovation center of really accepting this company as the main provider. I gave you an example of AI Doc. AI Doc does machine learning in CT scans. They started at Sheba. Two people outside, two came from, graduated from the Israeli army, and one was a resident for radiology at Sheba, and they started a company within the hospital. They actually were there like for 3 years, day and night, really went from all the cities of the head, moved to the chest. They got already, if I know of 2 FDA approvals. It could be that there's something new since I was updated. And the algorithm is totally embedded within the system. So for example, we had a few months ago, a resident was about to finish her shift at 7 a.m. and saw that, and the CT scans come from the emergency room. They are written on the computer screen for the physicians to be read according to the time that they came in. So the one that came, the last one, is actually the last on the list. And she saw that this algorithm was turned yellow, like it means that the algorithm detected something abnormal. She opened and came up to be the first one on her list. And when she opened this head CT, she saw that there was a stroke on that patient that was actually still in the ER. She called a neurologist who didn't even know that there's a patient in the ER with a stroke. And apparently the patient actually was she held her chest before she lost consciousness. So the whole workup at the emergency department was around a cardiac problem, but she had a stroke. So this is an amazing example of how an algorithm can change totally a workflow, save time, change the way the physicians can work, and create a tool that can really change the decision of how to take care of patients. Strategic partners. So like I said, we have a few companies, mostly pharma companies that are interested in our data, but also Boston Scientific that does pacemakers and so on. And Microsoft was there from the beginning on, and we did a few things with them. First of all, we have the lab, a lab of data in the cloud. We were the first one in Israel to be able to really create a lab that can create for us a platform to make data accessible for our partners. So if this is with the industry, like startup companies or big companies, or even if this is with the academia, we don't give up. We don't give away the data outside of the hospital frame, and we really just making access to that. So this is a good way for us to control it. And the second things that we're doing now with Microsoft, or trying to do, is really to create a path of how to bring this hospital to this new phase of being based AI by doing the digital transformation. And I will elaborate on that. Just the academia, like I said, we have a few students from data science from different universities that are interested in doing the thesis and projects. And I see here Talia, that is one of the students, to do it on medical data. And the idea is really to bring into our world smart people from your world, as we really need those technologies in healthcare in order to be more effective. We also have an MBA at the IDC in Herzliya in healthcare innovation, but it's really like it's a business program. We teach a lot of thinking, like design thinking and innovation, and what does it mean to do innovation in healthcare in these days. But it's definitely not technologically based. We have national and international network. The idea of that is really to see how we can solve problems that all of us have, and a problem that Sheba has, we have also in the US. There's nothing really different. So it's thinking together about problems, trying to solve them, and sharing data at one point. And I really hope that one day we'll be able to share in a much more easy way than what we have now. The data is not standardized. There are no standards really for Israel. I mean, the US, they were a little bit clever when Obama started the healthcare reform. He created a situation where all the electronic medical records companies have to work on specific standards. So there's no way that actually you will buy an EMR without having that standard. In Israel, it's different. Everybody does whatever they want, and in order for us to come to some kind of standard, each of the healthcare organization has to work by themselves. So sharing the data won't be easy, but actually we're working on that as well. And I just want, I mentioned the second thing that we're doing now with Microsoft, and I want to elaborate on that a little bit because I think that that's relevant for you. So hospitals are really, healthcare organizations are really looking for what will be the next thing in the way we deliver healthcare. Like, what is it that will make us different from what we are doing now? And it's clear for us that using tools from, that are based AI and machine learning will actually make the difference. Now we really wait for results, wait for diseases, wait for symptoms in order for us to be able to see something and to think about a problem. But it's clear that if we gather enough data, and we are based on the old data, but the new data that we gather is gathered in a smarter way than what we did in the past. Because when we gathered it over the years, we didn't think about analyzing it. We just thought about documenting. This is a physician perspective, about documenting that I will know what will happen to that patient and what we'll do next. Now we are thinking differently. How we will gather it in order for us to be able to analyze it and to create models that can predict something, that can actually we can rely on it. So taking this into account, the new databases that will be created in healthcare, if this is the IoTs that all of us actually have with smartphones or Fitbit or whatever, so based on IoTs or genomics, we haven't even started really to take genomic data on patients in a large scale. We take genomics on specific cancers and that's it. But you will see that, you see the biobank that Professor Segal mentioned before. We go there, actually. We are going to gather now a lot of data. We need to know how to build the databases and how to make use of them. So once we have all the databases in a good shape that we can really use it in a good architecture, we can put on them and create a lot of machine learning models in order to be able to predict what will happen. And this output, we want to bring back to the physicians and the nurses who take care of those patients in real time. Which means if a patient comes to the ER with chest pain, and we already gathered his vital signs and the EKG, and the blood test, and we know the genomics on that. So in real time, if you use the right algorithm, actually the physician that is standing in front of this patient can know this patient is going to develop a heart attack in 2 hours in 98%, or not. And then you know, actually, if I know that knowledge, and before waiting to see the results of the blood test and everything else, you can decide immediately to move the patient to for example, the cath lab or the ICU if needed. And the others, if it's like in 0% or in the 5% or less than 2%, then you know, okay, you know what, I can leave him for now to watch him in the ER, or actually I can discharge him home. It will change so much the way we practice and the way we actually use the resources that we have, that we'll be able to actually deal with that and not have such a lot of load, unnecessary load on physicians and healthcare institutions. I put this just as to try to show you how complicated it is, of course, this thought of gathering data, making process out of that in real time, and bringing the output back to the providers. Everything is, of course, will need to be at one point in the cloud. This is another challenge that we have. We're talking about a governmental hospital in Israel. When I came to the government to ask to get permission from there's a cloud committee in Israel to use data in the cloud. The main conversation was really about politics and how scary it is because Iran really wants to harm us and we cannot really use data in the cloud. So that's really the level of how many things we need to deal with, but I'm sure that it will happen. I mean, I see that the people are much more open to that than they were maybe 2 years ago, and we will be able to use things on the cloud more and more often. At this point, we use it, but it's quite difficult. So I know that we don't have, just in summary, the two things that I really concentrate when I build the center and what I really want to get. One is to see, always to put into my eyes, like what's the next thing that healthcare is going to look like? What are the tools? What are the technologies? And who is going to help me with that? If it's a startup company that can bring me one aspect of a small process that I'm looking at, or if it's a big company like Microsoft or other companies, it doesn't matter, that can help me together. But always thinking about where is healthcare is going to. People are going to be treated at home and less in the hospital. People are more monitored than before. Like there are so many aspects that change. Patients are more empowered. I mean, this is not just we make decisions. It's mostly really about the patients. Who is going to carry all the data? Maybe the patient needs to actually to carry his or her own data and not the healthcare organization. So thinking about all of this is what makes me actually create always this big picture and put those technologies within it. That's number one. And the second thing that is not less important is really how I'm changing the culture within my organization. Like what is it that it needs to be done that my physicians will want to be part of that? That it won't come from the management, okay, now you're going to do that and that project. But this is really like projects that my physicians and researchers and nurses and dietitians really come and think about their own problems, and that's the only way for us really to make use of the models that we develop, because we can develop hundreds of models. If the end user, which is the clinicians in this case, if they won't use it, then there's no point for that. So changing the culture is really from the day one was the most important thing for me. If anybody has any questions, I put our email here for questions, but also we're looking for people. We're looking for data scientists, data engineers, developers. We are by now 20 people, so if somebody feels that this is interesting for him or her, then please, you're welcome. Questions?
Any question, guys? Yes.
Can you speak please about the data protocols or
Yeah. So we have, of course, so to de-identify data, I mean, that's, of course, the basic. I mean, every project that we do goes through the ethical committee, the IRB or Helsinki in Israel, and every data is always de-identified, okay? We have a protocol of our own. We go according to the HIPAA regulation in the US. The government hasn't come up with her own guidelines of what really to do, how to de-identify data, but we work together with the government. I mean, I hope that one day they will develop. At this point, we all go through the HIPAA regulation. We also, so every data that goes to the cloud has to be, of course, de-identified. There's also synthetic data that we have a company that is producing synthetic data according to our own data, and in that case, we don't need the ethical committee approvals and so on. Yeah.
Do you have collaboration with other medical centers in Israel? Because I saw you have the HMOs. I was just wondering about other medical centers in Israel.
Like hospitals?
Yeah.
Yeah. So the question is if we have other collaborations with other hospitals in Israel. Yes, we nothing is yet, I didn't put it because it's not really done yet, but we are talking about it with Ichilov, with Rambam. I mean, we haven't really created any specific project yet, but we are very open for that.
So your aim is actually to lead the way in Israel, because there's no point of creating new things like that, because that's the future anyhow. It's like
Yeah.
there will be not only Sheba centers, but also
Yeah.
I guess Israel.
Well, it's a Sheba, at this point it's a Sheba center with the money that comes to Sheba. But it's definitely, we really want to be national-wide. So first of all, it's a governmental hospital, so there's no question that I always talk about it, that I'm happy to share everything with all the governmental hospitals and more even. There's a lot of politics, of course, but we are very open in our mindset, definitely. Yes?
While the startups that are working with you, they cannot use data to go with it to other hospitals in the world. So what are they getting from it?
So,
How is it working for them?
okay. That's a good question. When I entered this world, I was quite amazed to see that startup companies create their own data banks. I mean, they really go and gather data from different resources. And then one day I was sitting at MIT at the media lab. I was I was a faculty at Harvard Medical School. I did a project at MIT. And I saw an American startup company came to me with a chest X-ray. And on the bottom, it was written Klalit. And I said, where did you get that chest X-ray? And he said, from an Israeli startup. So Klalit worked with an Israeli startup that gave this X-ray to an American startup that had no relation to Israel. Now, what does it mean? And why do we really care about it? Data is really a private thing. I mean, and we need to understand, I want innovation. I'm the head of the Innovation Center. All I want to do is really to create better health by bringing new technologies. But we shouldn't forget that this data belong actually to somebody, that we shouldn't really use it. I mean, we should use it for research and innovation purposes, but there's no reason for us really to start selling it to a third party. And we try, and with all the openness that we have now, it's very strict. We don't give away the data outside. They can use it. They can create their algorithms within the cloud space, the workspace that we created them. They can sit us. We have places for them to sit. We can even create access to data from a remote care, but we don't really want our data to go around. The next lawsuit will be there. I mean, if in the past it was against ER docs and gynecologists in medicine, then I'm sure that it will be the next one in data.
So how will it be business-wise?
Business-wise, they develop technologies. They don't need data. I mean, they develop technology, and they can use the technology and use it and check it on other data resources. There are ways now to do. You don't really have to gather all the data in order to make your algorithm better, right? You can create it and use it in different places and to make it better.
But the machine learning is based on this data.
Yes. But they don't need the data. They create the algorithm. So they take out what they created, they don't need the data for that. If they want to prove it in an article, for example, sometimes it happens. Startup companies normally don't want the articles. It's mostly the physicians. But sometimes when you want to prove it, then you need to show it on the data. That's totally fine. We will give it for that. We actually are obliged to keep the data set for every specific project that we do, about 7 to 10 years according to the IRB committee, the ethical committee. So we keep it, but without the hospital walls. We have to be careful with that, right?
Maybe last question.
Yes. Yes.
Hey, thanks for the presentation. Was good.
Thank you.
My name is Krishna. I work for Intel AI out of Germany.
Okay.
So I have many questions, so I can come
Yeah.
after the presentation. So one of them is, I work closely with radiologists,
Yeah.
the hospital information, workflow management. We build models, and we compare it with how the doctor performs. Okay. So one of the things that I've seen is it's very tough to convince the radiologist to actually use the output of
Yeah.
technology. How do you do
Yeah.
that, Sheba? And what is the
Right.
what that is?
So I mentioned it on purpose because I know that that's a huge problem elsewhere. I don't convince. First of all, seriously, from day one in the Sheba, so I came 2 years ago, from day one I went to 3 to 4 departments every week to tell them about what we are doing in order for them to work with me on projects. I have a call once a year that they can come up with new ideas, and I give money to develop it together. So I have money normally for 10 projects. I get 100 applications by now for every call, which means that once you start really from down, like trying to engage and make physicians come to you with their own needs. I'm not taking care of my needs. I really want to answer their own problems. They will use it. Not just that they will use it, they will help to develop it, and they want to use it. What happened, for example, with the radiology, the AI doc, so like I said, the third one from the 3 established or founders, one was actually a Sheba doctor, so it came from the department. And then once you see the results, physicians want it. After this case that I just told you about with the stroke, we got the physicians asked us to implement this technology with their own private computers where they sit in the radiology room. So once they see that it helps them, they don't want to stay behind. Actually, they feel that it will make their work even better because they will first answer all those acute cases, and then they will go later to the other cases. So I think that really involving the physicians, the end users from the beginning on is the key.